In this case, we will discuss the pathways to the diagnosis of prostate cancer in a patient followed during 10 years. I have nothing to disclose. A 54 years old patient with no family history of prostate cancer, a PSA in 2011, 6.9. He was asymptomatic, and rectal examination showed 40 grams prostate with normal consistency. Transrectal ultrasound guided biopsy showed no cancer. During follow-up, the PSA was oscillating between 6 and 7, and in 2014, it increased to 7.5. A multiparametric MRI showed an 8 millimeters lesion and the transitional zone, hypointensine T2 and hyperintensine diffusion-weighted imaging. A combined systematic and targeted biopsy showed no cancer. After 2 years, the patient presents lower urinary tract symptoms. He was given tamsulosin, and in 2018, the PSA increased to 9.9 with a density 0.16. A multiparametric MRI showed the Pyrus 4 lesion in the peripheral zone. A combined systematic and targeted biopsy with a cognitive fusion showed no cancer, only benign prostate hyperplasia. After 1 year, the PSA increased to 11, and the multiparametric MRI showed no lesion with a prostate volume of 75 grams. So the Pyrus 4 lesion disappeared on repeat MRI after 1 year. In 2020, the PSA was stable, but the patient worsened his lower urinary tract symptoms. Our decision is made based on clinical parameters and MRI, and we don't use biomarkers so far. PSA density 0.15, the upfront MRI was normal, normal consistency prostate with enlarged 75 milliliters in a patient is 63 years old with multiple prior negative biopsies. If you use the Rotterdam prostate cancer risk calculator, the patient has only 1% risk of significant prostate cancer. And if we combine the MRI that was normal, also he has 1% risk of significant prostate cancer. If the Pyrus was persisted for, the risk of significant cancer would be 12. The patient worsened his lower urinary tract symptoms, and we decided endoscopic bipolar enucleation. It was difficult with a postoperative sepsis, and histopathology showed no cancer. 3 months after enucleation, the PSA dropped to 1.2. This study assessed the role of PSA monitoring after hormone laser enucleation of prostate. After enucleation, if the PSA is more than 1 and the density is more than 0.1, these patients are at risk of harboring significant prostate cancer, should be biopsied, and here clinicians should be aware and the shift of PSA after enucleation. Multiparametric MRI is an upfront in a diagnosis of prostate cancer. It was highly recommended in prior negative biopsy, now is being recommended in biopsy naive patients. 2 strategies: to rule in significant prostate cancer or to rule out clinically significant prostate cancer and use the MRI as triage test. The PROMISE trial and the Precision are 2 landmark prospective studies that assess the role of MRI and the diagnosis of prostate cancer. For Precision trial, the MRI pathway with targeted biopsy detects more significant prostate cancer and less insignificant prostate cancer as compared to systematic biopsy. The PROMISE trial shows that MRI has a high negative predictive value, and if it is normal, only 1 in 4 may have Gleason pattern 4. So from these 2 studies, the suggestion was MRI for all, targeted for many, and systematic biopsy for those with high risk. So we have new tools. You have risk stratification tools in addition to MRI to improve the detection, the decision making. And the literature, there is an added value of combining biopsies. The targeted biopsy and systematic biopsy combined provides the greatest detection of significant prostate cancer. And the added value of MRI targeted biopsy is higher in prior negative biopsy than in biopsy naive patients. That's why European guidelines strongly recommend to combine targeted and systematic biopsy and biopsy-naive patients, and recommend only target biopsy and prior negative biopsy patients, but the strength of rating is weak. Can systematic biopsy be omitted? This study shows we can omit systematic biopsy in men with PIRADS 5 and PSA density greater than 15%. If the PSA density is superior to 0.15 nanogram per square milliliter, if standard biopsy is omitted, only 4% of significant prostate cancer are missed. The limitation of MRI is the high rate of false positive, as it is shown in PROMISE trial. In PROMISE trial, the rate of false positive is more than 40%. When we have a PIRADS 4 or 5 lesion and the biopsy is negative, what next? This study shows that false positive MRI lesions are distinct from significant cancer-associated lesions in patients from PROMISE trial. And the lessons from PROMISE trial was these significant cancer-associated lesions, these true positive lesions are mostly multifocal, with larger index lesions, are more conspicuous and more visible in all sequences, with a more diffusion restricted and higher PSA density. So for indeterminate MRI phenotype, PSA density and EDC could predict significant prostate cancer. PIRADS 4 or 5 also can be benign lesions, and this study shows the follow-up of men with PIRADS 4 or 5 abnormality on prostate MRI and non-malignant pathological findings on initial target biopsy. 18% of patients with PIRADS 4 or 5 abnormality have no cancer on target biopsy. And PIRADS downgraded and repeat MRI in 73% of cases. So the persistence of PIRADS 4 or 5 predicts a high risk of missed cancer. This raises a worthy question. Is upfront MRI always necessary? This study shows that we can reduce unnecessary prostate MRI by using clinical parameters to predict negative and indeterminate findings. When the PSA density cutoff is 0.078, the negative predictive value is very high. So this leads to 29% fewer MRI to be performed and only 2 clinically significant prostate cancer to be missed. So MRI has limitations. There are many cases of false positive and false negative, and also interleader variability. So we have, in addition to MRI, to find new tools. These tools are risk calculators, biomarkers, and new models. Only 2 of them are FDA approved. And the PSA density with a cutoff of 0.15 is a valuable clinical parameter, cost-effective, that improve the decision-making and selecting patients for biopsy. The European guidelines recommend risk calculators and imaging and recommend biomarkers, but the strength of rating is weak, while NCCN guidelines recommend to consider biomarkers. This is an excellent review of risk stratification tools and prostate cancer diagnosis, combining biomarkers, risk calculators, and imaging, and shows the role of prediction medicine and the decision making. The tools are either risk calculators, including standard parameters, or risk calculators, including biomarkers next to clinical parameters. The MRI is considered as clinical biomarker, and the risk calculators, including MRI data and the combination of novel biomarkers and MRI. So there are many strategies, combined strategies to diagnose this pathway, combine risk stratification tools, either upfront risk calculator with standard parameters and if indicated subsequent MRI and biopsy, or upfront risk calculator with standard parameters and novel biomarkers and if indicated MRI, or upfront novel biomarkers and if indicated subsequent MRI. Different scenarios combining biomarkers and MRI. And this study shows the different possibilities, different options, either upfront biomarkers or upfront MRI. So many options, and they think the choice depends on what is affordable, what is available, and what is easy to perform. Thank you.